All right. Short one on the docket. We've got 4 studies to get through today. So let's start with the first one, Insights into Achilles tendinopathy Risk and Protection in Runners. This one's a prospective study. And really what they were looking at was running economy and mechanics, just seeing if there was anything that they could parse out as far as risk factors for those that go on to develop Achilles tendinopathy. And there were a few things that they found, and I want to talk about it a little bit. So we're going to skip the method. We're going to just jump right to the conclusion, and then we're going to go back to the results. So first up, conclusion. They identified a lower peak angle inversion moment, so kind of like the same motion that you would do if you wanted to roll your ankle, inversion, a lower peak ankle external rotation angle, and a greater running volume as significant predictors of the onset of Achilles tendinopathy. So they think that targeting biomechanical factors and running volume may help prevent Achilles tendinopathy. I think of the 2 recommendations that they had between targeting biomechanical factors and running volume, the lowest or the easiest thing to work with a patient first is definitely going to be the running volume, because a lot of medical interventions can actually be either improved upon in general or avoided entirely if adequate training principles are actually applied. Because one of the biggest issues in the rehab space and musculoskeletal medicine as a whole frankly comes down to not the fact that we need new technologies, new techniques, new approaches, new this, new that. Are they good? Well, certainly for the most part, they are good. They will enhance care. However, we always have to go back to the basics, and the basics still are not being applied well, whether it's from a clinician standpoint or being adhered to well from the patient standpoint. And those are the basics. That is genuine basic training principles, applying the right load to the right patient for the right duration at the right intensity for the right amount of time. So when you're working with a patient, the most potentially impactful thing first is going to be handling the training issue. In this one, ergo, the volume principle. So very often people will, at least in my neck of the woods, not do very much over the winter, then go right into training very, very hard, prepping for 5K, 10K, half marathon, full marathons. And they're not doing that much over winter to prep for it. And then they realize that in order to train for the volume that they want, they typically then go either too long or too far of a distance, and or they pick an inadequate speed or pace or cadence. And all of those factors lend itself to not allowing the body to adapt in an appropriate manner. And so it's going to apply the brakes because it can't quite handle in an inefficient way the stresses you're putting through it, and you're going to develop Achilles tendinopathy. Now, there are certainly things to discuss as far as the biomechanical principles in running, and there's definitely a time and place to address those biomechanical principles, but it should not be in place of or in front of training volume and better training principles. And I can only think of a few instances where there is a legitimate biomechanical unique issue with the patient. So if we're talking gen pop, volume first all day, every day. There are some instances that we can always make the case that there are exceptions to that rule, but I will apply the rule first. So if we go back to the results of this, they actually found that of those risk factors, one was positive, the other 2 were negative. So if you did this, less chance. If you did these 2, more. So let's break it up. The higher peak inversion ankle moment actually reduced the odds of developing Achilles tendinopathy. Again, that's not something I'm really going to delve into as far as, why is that? How is that? I mean, we could make the excuse and argument that it might lend itself to either more efficient running economy, more even load distribution, and we can get into the discussion of how the Achilles tendon is actually different types of fibers orienting themselves in different angles. And so by having that better inversion moment, maybe we actually have better inter-tendon tenocyte loading and friction. And like we could go into that, but I don't want to bog down this video. I also just don't feel like talking about it right now. I'll be honest. But then the other 2, the volume and the lower peak ankle external rotation. So basically, if you're not allowing your foot enough room going out, so if you're kind of locked in this way, it kind of makes sense. Like it's not that having a significant duck foot, like if it's all the way out, is going to automatically then be protective. In my understanding of how this works and how the body will utilize this is if you only have this much space where your foot is allowed to land, that's going to target a specific part of the Achilles tendon and not allow for an even distribution of forces to disperse the load over the training volume. If you're allowing yourself more external rotation, it's not that every single stride and landing is going to land an extreme external rotation, because that would just wind up being the same problem. It's now you went from this amount of acceptable foot landing position to this much. And so having that additional play, the additional resource available, means that your foot can land in different ways that will then distribute load differently and allow you to achieve the volume you want by not locking yourself into an exact foot position, which is going to then very specifically load in a repetitive manner that will lead to our tendinopathy. But that's enough of that paper. I want to move on to, let me scroll up to the title of this one, The Effectiveness of Manual Therapy as a Prophylactic Treatment for Migraine, a randomized controlled trial. Couple things that I wanted to say about this one. One, this study was done in Europe, in Amsterdam. And so when we make references to different techniques, tools, and how different professions may be categorized, they are vastly different between countries. I mean, it's one of those things that should be obvious, but it's not at the same time. It's not just from a system standpoint that things are different, but even in the research, you also have to then parse out who did the intervention, why, when, and how, because those things will be different. Let me use a different example. If we're talking football statistics in the US of A, that's going to be American football. And so you know that you're talking about American football and your stats make sense to other Americans. If you talk about football anywhere outside of the United States, it's going to be soccer. So your stats, even if you're using the same terms, what game is being played is different. You're still talking about athletes. You're still talking about a game where you score points. You're still talking about a game that can last hours, that has break periods. Like there's a lot of overlap. However, the actual thing that you're studying should be interpreted differently. So case in point would be, classification of professions, certain terminologies that you don't want to just leave as face value. Like, they talk about manual therapy. Well, what is manual therapy in here? Because, is that muscle work, manipulation, mobilization? Because again, they're talked about differently. So if you want to be precise in what you're reading and what's being talked about, understand where the study's coming from, and then just double check what they are classifying different interventions and therapists as in these studies. One last one before I get into it is you should do this because even stateside, if you look at a lot of manipulation studies, a lot of the ones that'll draw scrutiny, you'll see the methodology, 3 PTs that are sub 5 year did these interventions. Okay, is that good or bad? Neither. It just is a fact. The problem is now it's being directly compared to how other professionals are being trained and then their potential results with that technique. And it could lend itself to making an erroneous conclusion because of who, what, when, where, and how the intervention was set up. Because talking with a lot of and working with a lot of physical therapists, when it comes to manipulation, which again, everybody, not everybody, the general musculoskeletal realm talks about manipulation on a grade 5 scale. Chiropractors usually just think manipulation is manipulation, even though it's grade 5. We don't usually parse it up because a lot of us only do one thing. However, when I work with physical therapists and we talk about manipulation, a lot of them will avoid anything above or going into the neck. So if they're doing a study where they wanted to train these PTs on how to do a neck manipulation, or if they kept everything to the thoracic spine, that's going to play out differently potentially in the results because of the again, it's not standard of care, but the standard practice that I've seen working with learning from the PTs around here. If they're doing manipulations, it's almost always and only in either the mid back or low back. And even then, there's only a handful of techniques that they do. And again, this isn't a knock. This is just personal experience trying to discuss research here. And so they don't often have lots of different ways to approach the same intervention, but match it to a different patient that makes it more comfortable, tolerable, and might lead to better results in the study. Now, does that change the effectiveness necessarily from the population standpoint of manipulation? No, but it allows us to enter the conversation with a better footing, a better understanding, and a more precise outcome when we're talking about something. That is a long-winded way just to say, do your due diligence. When we look at this study, the effectiveness of manual therapy as a prophylactic treatment for migraine, you want to just double check a few terms here to make sure that you understand what you're talking about, and so that we can bring it to you in a more precise way. So this one, I'm going to talk about methods, then conclusion, then results. So methods, this is a randomized controlled trial in a primary care setting with participants that have migraine and neck pain who were either allocated to manual therapy or universal care or standard of care, aka their general practitioner's management. Manual therapy group included mobilizations, so there's one thing to ready to note. Exercises, there's something else to note, but I'll get into that one. And myofascial techniques, and that's a broad category that frankly could mean just about anything. Follow-up assessments were performed at 12, 26, and 52 weeks post-inclusion. The primary outcome was the number of migraine days. That's important to remember, the primary outcome. Secondary outcomes, or secondary things that they measured, included migraine intensity, disability, medication use, neck pain intensity, neck muscle endurance, pressure pain thresholds, allodynia, which is going to be the patient perceiving a painful stimulus from what shouldn't be painful, and then perceived recovery. So if we jump to their conclusion, manual therapy, including postural and craniocervical exercises, was not superior to usual care in reducing migraine days and most secondary outcomes. Still, patient preference and treatment satisfaction for manual therapy were high and may be considered in migraine management. So, you read the conclusion, oh, manual therapy, big whoop. And you have a little bit of an argument. Let's go back to the results and then have a little bit of a discussion. Results. There were no significant between-group differences in migraine days or most secondary outcomes. Compared with usual care, the manual therapy group demonstrated significantly higher pressure pain thresholds over the occipital muscles and reported greater perceived recovery at both 12 and 52 weeks. Use of prophylactic medication was higher in the usual care group throughout follow-up. What the heck? Why the big? So again, their primary outcome is what they're basing the conclusion off of, in which case their conclusion is absolutely correct and in line with what they were measuring, which means if we're going by this study alone and I have a migraine patient, I am not telling them that I can reduce their number of migraines that they have on average compared to if they don't see me, or compared to if they get manual therapy or no manual therapy. However, this is migraine patients with neck pain. The manual therapy group had a couple of key points. One, they had better pressure pain thresholds, so their body wasn't as hyperreactive to stimuli in the suboccipital region, which can irritate people, and we could then presume that they have other downwind factors that we might be helping with the manual therapy. Like I remember a guy with greater occipital neuralgia who had difficulty even sleeping on a pillow, so his sleep was disturbed. Well, if there's the chance, and I'm not saying that greater occipital neuralgia can necessarily guaranteed be helped with manual therapy, but if we take it where somebody may have such an an issue with that neck pain, that they're having trouble sleeping. Sleeping is a big part in overall recovery. And if the manual therapy reduces the pressure pain threshold, or they might actually be able to sleep better, a downstream benefit to the manual therapy group may be secondary factors that lead to better overall outcomes. Now, two, the usual care group used more prophylactic medication. Medications have their own side effects, which means the risk profile comparisons have to be discussed. So the person receives manual therapy, it has its own risk profile depending on which manual therapy treatment you use, but then compare that to the medication that the patients might use prophylactically. Aspirin has a not insignificant risk profile between visceral damage and death. Other medications have other side effects that may be mitigated or avoided depending upon the person's approach. So if they go manual therapy versus medication, you understand the risks with manual therapy, but you also understand the risks of medication. I have a bias, but I might lean towards manual therapy for obvious reasons. Now, the last thing that I wanted to talk about before I discuss their exercises was the patient had a better perceived recovery. We've already had a lot of studies and videos discussing the patient's perspective on their recovery as well as placebo. If the patient has better perceived recovery, that means that in this population that already has significant comorbid factors, including other mental stressors and conditions, which can include but is not limited to depression, anxiety, um, et cetera, et cetera. If they have better perceived recovery, they're seeing themselves as improving better than if they didn't receive care, which means they're showing positive results, they're gaining momentum, which has huge implications when it comes to managing and mitigating the overall person in front of you suffering from migraines, because this is a very debilitating condition. I'm actually going to leave it at that because I don't want to spend another hour talking on that. Last but not least, these patients received exercises. Well, those exercises were given in the form of a pamphlet to do and take home, and they were just encouraged to do them. Looking through the study, they didn't really receive any physical therapy guidance. They didn't receive any additional exercise guidance besides what was in the pamphlet. Having worked in clinics that have done that before, the adherence is often poor at best. The understanding is poor at best. If you ask the patient to demonstrate these exercises, a lot of the times, especially when it comes to neck muscles, they're not doing it in a way that would benefit the condition because they're not hitting the muscles that you want to hit for the reasons you want to hit them. So again, I have issues with a lot of things in this study. It's kind of why I wanted to bring it forth. But before I work myself into a tizzy, let's move on to the last two studies. Progression of spinal MRI findings predict change in disability in young adults with back pain. Yes and no. So MRI is a powerful tool. You are not your image, however, so take it with a grain of salt. I tell my patients all the time, depending on your age, they either might or they will for sure find something, because that's just the way life works. And it's up to all parties and powers that be to really figure out what parts of your MRI are factoring into your condition presently. Because if you just go out to 100 people ages 50 and up and you took a look at their shoulders, almost all of them have some sort of lesion in the rotator cuff. So how many of them are actually complaining of rotator cuff related issues? Exactly, not nearly as many that actually have a lesion, quote unquote. So let's go into this one. Let's see, 561 participants, age range 18 to 40 years old, slightly more women than men. Went to an outpatient hospital spine clinic. Disability was assessed using the Morris Disability Questionnaire on a scale of 0 to 100. I'm saying that number for a reason. Whole spine MRI was obtained at baseline and 4-year follow-up. Progression, which is defined as new or worsening findings of vertebral end plate signal changes, disc degeneration, and disc herniations, was assessed. So progression, which was defined as new or worsening findings as you wait at least 4 years, where life doesn't stop affecting a person. And sorry about that, mic cut off for a sec. So in this thing where you're already measuring people and you're measuring people over time, where your spine will adapt and change over time, we can already kind of make sense that things aren't going to be clean in a lot of the people 4 years follow-up. But let's go into the results and conclusions. The main baseline disability score was 56 on a 100 scale, with a mean improvement of 18 points over 4 years. When the MRI progression was analyzed separately by the findings that we previewed, so their vertebral end plate progression, disc degeneration, disc herniations, etc., as well as subdividing it by region, only a few specific findings were associated with changes in disability. In contrast, broader measures of MRI progression, incorporating findings across the whole spine, and summed up as either binary or continuous variables, basically they're getting into a lot of research talk. These were associated with less improvement in disability. Now, specifically, so if you kind of zoned out because that was a lot of jargon, zone back in. Specifically, any progression in the whole spine was associated with 5.1 points less improvement. So we'll get back to that. Furthermore, cumulative progression of MRI findings was associated with less improvement in overall disability. So they concluded progression of MRI findings across the whole spine was associated with less improvement in disability. The results suggest that new or worsening structural changes may impact back pain outcomes and may further depend on their distribution and cumulative burden over time. Two things that I want to talk about. First, on a 100-point scale, with the mean score of 56 and with the average improvement being 18, those people that had new or worsening signal changes over 4 years had about a 5.1 point less improvement, which means not a whole lot. So, I mean, think of it as a grade. You know, you're giving a class a 100-point quiz at the beginning of the trimester or the semester or the beginning of their freshman year, and they score an average of 56. Ooh. Now, you kind of let them cook and stew and learn. Most of them improve by 18 points. So, let's just say for our sake that a higher number means better, okay? So for the rest of this conversation, because of the analogy I'm using, higher number will be better now. So if they go from a 56 up to a 74, that's pretty darn good. However, a couple of the people that you labeled as troublemakers and that you needed to keep an eye on still got a 69.5. So they are still almost the same as the rest of the class. That's on average, though, which means a lot of these people may have the same exact score, but there's one or two really bad apples that didn't improve at all or barely, which could be dragging the whole group that you're analyzing down. And again, I don't have access to the specific tables or numbers to really parse that out for you here, but it's something that we have to consider, is that these are averages across 561 participants, and that they took the group that had those that were worsening and show that they had an average reduction in improvement by, again, a minimal number average. And was that everybody was about 5.1, or was everybody like a 2, and then you had like 3, 4, 5, 20 people, whatever it is in the group, that just really didn't improve at all because their biomechanical, their structural issue progressed to the point where, okay, yeah, it legitimately makes sense, rather than something minor where it progresses from mild to moderate end plate change, or they had a mild to moderate spondylolisthesis, where it's just like, it doesn't make sense for a person from a just purely mechanical standpoint to have issues. to this person went from mild or moderate all the way up to severe and or significant bio biological structural changes, in which case it's like, well, yeah, okay, in that person, we do talk about the biopsychosocial model and that not everything is structural, but that person's structure changed to such a point that you can't ignore it and the body will be trying to adapt around it. I mean, I had a patient, a trucker, a couple of years ago that I think about that we sent for imaging because he actually was coming out of a work comp, so we had access to his imaging. And his body actually was building an accessory, so an additional bone in the front of his sacral base, to help literally buttress and support from underneath the L5 or lowest vertebral body, almost completely slipping off. So spondylolisthesis going forward off of his sacrum. Like, that is what he was dealing with. So again, biopsychosocial, it's like, well, not everything's biological. In his case, his body was literally laying down secondary bone, ossifying the area, reducing all of the local region's movements to adapt and stabilize. So yeah, the symptoms that he presented to me with, including low back pain, reduced range of motion, and he was starting to develop some nerve issues going down his leg, made sense because his body was literally adding bone all around the area to shore up what it was dealing with. So the biopsychosocial model is the best model that we have to date, and too many people ignore the biological because we course corrected. Like, there was a point in time everything was purely biological mechanical. That's a bad lens to look at it through because it leads to erroneous, egregious, and terrible medical interventions for patients that do not need them at the time, and it leads to patients not actually recovering because they go through whatever it is, let's pick surgery. They come out of surgery and they actually have no improvement in their condition. So purely biological was no good. We course corrected into the biopsychosocial, but emphasizing now to the point too much on the psychosocial, or let me rephrase, we ignored the bio part of that entirely, and we're not willing to have the conversation again. But the entire setup, the biopsychosocial, is the best model. It includes the biological. And in this case, in this study, we have to make the presumption that it's not telling us the whole story. Was it one or two that had such significant outlier numbers that brought the average down? Even then, the average isn't actually that much worse by comparison. Yeah, it's something to talk about, but it's not something to be doom and gloom or to make that much of a conclusion, because then if you're using MRIs as a tracking of progress when it comes to back pain, that already has been debunked. So you got to be careful when you're taking a look at the studies that don't necessarily directly conflict with the evidence out there, but they're opening an avenue for conversation that you have to be prepared to have from multiple angles. Because if you read this one point blank and ignore the rest of the MRI studies, we may be bringing back MRIs to track, back pain and other, for the person's condition, negligible back lesions that don't really have an effect on their ability to perform different tasks. And I'm thinking that, these studies then have an influence and an impact on not only direct private insurance reimbursements, codes, and approval ratings, but they have effects on personal injury. They have effect on workers' comps, individual medical examiner criteria. They have effects on, changing disability, whether it's questionnaires or scores that affect people when it comes to returning to work, returning to play, etc. So you have to be careful. I'm not saying don't do these studies and don't interpret them adequately, or that's not what I'm trying to say. Don't avoid these studies or toss them out entirely because of what I'm saying. Take them with a grain of salt, arm yourself with the knowledge, and don't just jump to conclusions with any one study. Take a look at the whole summed up group to make the best informed decision, because these things will affect policy, which then affect everybody directly or indirectly, whether it's through private insurance, work comp, etc. Lastly, something short. Big breakfast diet composition impacts on appetite control and gut health. A randomized weight loss trial in adults with overweight or obesity. They were really trying to look at, what factors play a role. And they parsed out fiber and protein. And of those, they said protein has the biggest overall impact, even more so than fiber. which is cool, which is great. It still backs up what a lot of people are saying, including myself, that you want to pick a very filling breakfast and start your day off right. And a lot of the time, no, not a lot of the times, your best options are quality protein sources for sure, but you don't ignore fiber. This society already has an epidemic of not getting nearly enough fiber in their body. So even though this study is reinforcing what is already known, which is protein is great for you, it's filling, and it has a huge impact on your weight, on your general health, et cetera, et cetera. What I don't want people to take from this study, if you find it, if you read it, is that, oh, protein is better than fiber, so I don't need fiber, and I should really focus. It's like, no, both are extraordinarily healthy for you. You need both. We should be getting all of it. And don't really ever look at these studies that say one is better and then only focus on that, or focusing on trying to be optimized in everything. Because one thing, even in this study, if I jump all the way down to near the bottom here, so they also did fecal analysis of these patients just to see what was their gut health and GI health. Uh, the fecal microbiota analysis, so their bacterial distribution in their feces, which is something that we will utilize as far as making a gauge as to how diverse and healthy and robust the digestive system is. The fecal microbiota analysis showed beneficial groups of bacteria, including different named ones, were significantly increased in proportional abundance on the high fiber weight loss diet. So eat both. They're great. Get your protein in, find your healthy fiber sources, and let's all improve our diets for better overall health. That's what I got for you this time. Thanks for listening to my rant.